Okay, good morning to everyone. Please, if you can have a seat, you are going to start the presentation because for time reasons it's going to be late and we would like to have time for discussion at the end of the presentations. This session has been titled A Contemporary View of Classical Arrhythmia Circuits and Topics. So we are able to review classical topics, but really present in our daily clinical practice in the EP lab. We have three presenters, very experts in the field that we are going to treat here. And I have the pleasure to co-chair this session with Professor Jesús Almendral. Jesús Almendral is already known for everybody, so he doesn't need any presentation. And I just go introduce myself. I'm Conchi Alonso, working in Barcelona in the Hospital of São Paulo. So I think we are ready for the first presentation. We have the Professor Demosthenes Katritsis, which is going to talk about the mechanisms of AV nodal reentrant tachycardia.
Thank you, Madam. Mr. President, it's a real pleasure, actually, let alone the privilege and the honor to be here. Having been asked by this nice organization, Congress, to visit Madrid and Spain, a country near and dear to my heart, and have been asked to talk about AV and RT. First of all, allow me to dedicate this lecture to my mentor and teacher, Mark Josephson, who unfortunately has left us a month ago, and to whom I think that most of the people in the room owe too much by means of training and knowing what arrhythmia is about. Now, these are my disclosures. And why is AV and RT relevant, particularly in the era of AF ablation? Because it's the most common arrhythmia you may encounter in clinical practice. I mean, the most common regular arrhythmia you may encounter in clinical practice. And if you take these numbers and you translate them in your population, which is, I think, something like 45 million, you should expect 13,000 new patients with AV and RT every year appearing in Spanish hospitals. And if you see in your ablation cases, you realize that when you ablate regular tachycardias, half of them are going to be AV and RT. So the most common regular tachycardia you are about to see in the outpatient and ablate in the lab is AV and RT. Now, what's the paradox with this arrhythmia and why it's so fascinating? Although it's the oldest arrhythmia we have studied since 1983 when Mainz described the AV node duality, we don't know where the circuit is. That's why it's so fascinating. We have this traditional view of the slow and fast pathway with the typical AV and RT, the slow fast and the fast slow and the slow slow. And I don't know if you have, do I have a pointer here to show you? Yes. Sorry. And yeah, and you may have the slow AV and RT, you may have aberrant conduction, no aberrant conduction. All these are formalities which we know. We also know that you do not need the atrium or the ventricle to participate. It's an arrhythmia confined in the AV nodal area. We have published with Mark main papers showing that there is independence of the atrium and the ventricle from the tachycardia. So you may have AF or whatever and AV and RT, or you may have AV and RT with 2-to-1 or 3-to-1 conduction. However, we have lots of myths and facts with this arrhythmia, and I would like to go with you one by one. I remember being in Spain, I don't have to remind you who this is, but I remember since my years in Oxford, one of the questions they have in order to admit students, they used to ask them, do you think that El Greco used to have these elongated faces always in his paintings because he might have a vision problem, and by which he had elongated figures appear in front of him? And whoever student said yes, he was thrown away. Why? Because although everybody would have thought that this is the right answer, actually it's not, because if El Greco had this vision defect and which made him to perceive persons as elongated, then they would see them elongating his paintings as well. And in this case, he would have avoided painting them like that. So what's obvious is not the case, and this could be more than true with AV and RT. First of all, we all used to know that AV and RT is a disease of the young. because usually supraventricular tachycardias, most of the time, are disease of the young. This is not the case with AV and RT. On the contrary, the higher the age, the most probable is to find AV and RT. And actually, if you have a patient who is in his 50s, in his 60s, then it's most possible to find AV and RT than when he is in his 80s. And what happens is that as the time passes, AV and RT actually tends to become more aggressive, which is the contrary, the opposite to what happens with pathways, because accessory pathways get to fade away with time and disappear. With the AV and RT, the opposite happens. Now, if you have ablation, if you have to ablate AVF patients and you submit them to EPS, you see that 7% of them are going to have an additional arrhythmia, and 3% of them are going to have AV and RT, which triggers the AF. So instead of ablating the pulmonary veins, we should target this arrhythmia first. Second myth, typical AV and RT. We all say that the earliest retrograde atrial activation is in the HIS. How do we know that? We don't, because most of the time in AV and RT, you have the coincidence of the V and the A electrogram, so it's impossible to separate them. In order to separate them, you have either to go and wait until the tachycardia stops. So you see here, the tachycardia stops, this is V, there's no A, so this has to be the A, by definition. So when you look here, okay, the first A is on the right HIS. However, here, if you introduce a ventricular extra and you capture the V, although you do not disturb the tachycardia, you see it's a constant interval here, you know where the A is, and if you go and put a catheter on the left side of the HIS, you realize that the earliest retrograde activation is actually not only not on the HIS, but it's on the left side of the septum. So AV and RT is not a tachycardia which is always accompanied by earliest retrograde activation on the HIS. It could be in the left or the right septum, on the left septum, or the coronary sinus source, and actually there have been described cases with AV and RT with earliest atrial activation at the distal coronary sinus. I'll come back to that. How do you put the diagnosis? Sometimes it's difficult. We have reviewed with Mark years ago the differential diagnosis of supraventricular tachycardias, and as you see in this table here, we do not use as a criteria on whether the earliest retrograde activation is on the HIS bundle or not. Now, we used to know that AV and RT cannot be reset from the ventricle. It's not true. Even if you have a HIS synchronous extra stimulus and you deliver it very close to the node, above the HIS, then you may reset the AV and RT. I know that it's a good criterion to differentiate pathways from AV and RT by giving HIS synchronous extra stimuli, but please keep in mind that it's not impossible to entrain the tachycardia with V. And if you remember, in the older times, we used to say that AV and RT is not entrainable by the ventricle, as opposed to AVRT, to a tachycardia with a pathway. However, we know now that both AVRT and AVNRT can actually easily entrained by the ventricle. Myth number 4, the upper and the lower common pathways. It's been lots of papers and lots of human effort wasted on this thing, which has no practical significance at all. First of all, the upper common pathway. The upper common pathway is being based on the assumption that you measure different age intervals during V patients and during AVNRT. However, as Josephson years ago has proved, the retrograde atrial activation is so heterogeneous from the circuit back to the atrium that it's impossible to consider an upper common pathway. And the same happens in the lower common pathway. We used to use this term in order to define conditions like AV block below AVNRT, which, however, it can happen without having any lower common pathway. And in any case, in order to measure these two entities, you have to rely on assumptions which may not be valid. And practically, there's no significance. So forget about upper and lower common pathways. I know our Japanese colleagues used to describe them in their papers. I've never ever seen any usefulness of these entities. Now, about a typical AVNRT, which used to classify as fast, slow, 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 we used to know you used to say and to teach that earliest retrograde activation is at the coronary sinus ostium. Again, it's wrong. You see here, typical, typical fast slow tachycardia, prolonged HA, AH less than HA, and the earliest activation is on the His, not on the CS. Here you have a slow tachycardia. And again, the earliest activation is on the His. So, as happens with typical AVNRT, the same stands for atypical AVNRT. You may have the earliest retrograde activation everywhere near the vicinity of the AV node, which I may remind you is a three-structural entity embedded into the septum. Years ago with John Cam, we tried to classify AVNRT in a review in circulation as fast, slow, slow, and slow, fast. And this is the traditional way of describing these tachycardias. And at that time, Mark Josephson sent me this picture, this electrogram. He asked me, Dimos, which tachycardia is this? It can be slow, because the AH is less than the HA. It can be fast, slow. It can be slow. It can be slow, fast, of course. So what tachycardia is this? It's unclassifiable by this traditional view. So we realized with Mark to go back to the basics and see what the real timing is of AVNRT. Please keep in mind that all the times which we measure, all the time intervals which we measure in AVNRT are relative. What I mean is that whenever you measure the HA and then you measure the HV or the HA, this means that these time intervals run simultaneously. I'll try to make it easy for you. So if you want to try to measure, to appreciate the fast pathway, you have to take a patient who runs both tachycardias simultaneously. I mean, he has slow fast AVNRT and then he goes to fast slow AVNRT, because this is the only way to appreciate the time intervals which characterize the fast pathway and the time intervals which characterize the slow pathway. So if you take such patients who exist, then you see that during slow fast AVNRT you have these relationships here. During fast slow AVNRT you have these relationships here. And if you add these intervals, you end up with two slow pathways, which means that if you know the cycle length of the pathway and you can derive from here the length of the slow pathway, then consequently you have the length of the fast pathway. So if slow fast is the opposite of the fast slow, this means that in these people, in these patients who have both arrhythmias, these numbers should be simultaneous, should be the same. However, when we analyzed 20 patients with these arrhythmias, we realized that what happened to be fast in the fast slow had nothing to do with fast in the slow fast. So fast slow and slow fast are not the opposite to the other. And then eventually we used to laugh with Mark with this thing. When James Cook actually went to Australia, he asked one of the Aboriginals, what is this animal? And the Aboriginal said kangaroo, which means, what's he saying? I don't understand. So we had the concept of kangaroo, which in the Aboriginal language initially meant I don't understand. Unfortunately, later on I realized one of my students at Harvard told me that this is not true. There is an explanation that it can happen in one of the dialects of the Aboriginals. The word kangaroo means not only I don't understand, but it actually signifies this animal as well. So this is the same with AVNRT. And eventually we decided to make our life easier and classify AVNRT either as typical, which means that the HA is less than 70 milliseconds, or atypical, which means that the HA is more than 70 milliseconds, regardless of whether the atrial activation is at the His, it's at the CS, or whatever. Now, where's the circuit? This is the answer. We don't know. unbelievable, but after 100 years where we study this arrhythmia, we don't know where the circuit is. However, we have some clues. First of all, could it be an isotropic conduction, as you know, Mark Johnson and Madison Spach claimed years ago? It could be. In the AV node, you have the preconditions, you have actually the conditions in order to create an anisotropic environment. However, if you go in histological studies, and actually there was another theory saying that it's the connection 43, the connections are, you know, the gaps are the bridges between connecting one cell to the other. So they are supposed to be, I mean, a genetically modified loss of connection function there, which creates all these conditions for an anisotropic environment. However, when you go back to the literature, you see that histology studies and patch clamping studies have failed to prove that the anisotropic tissue in this area is responsible for these AH prolongations and the jumps which we get with AV and RT. And even if you consider the orientation of the fibers, and you take propagation of the impulse from different points of view, and then again, you cannot prove that this anisotropic condition, the anisotropic conduction which actually exists there, is responsible for this AH prolongation which we have. In other words, you need an anatomic component in order to explain the typical behavior of AV and RT with jumps and all these things. Years ago, Andon Baker, a great pathologist of the heart, published a paper which showed that in the AV node, there are extensions, nodal extensions, to the atria. So the AV node is something like this. You have the node here, and you have two extensions, one on the left, one on the right. And we started then following Andon's, word to study this area, both from the right and the left side. Actually, it's very, very easy to record the hit from the left, either transeptally or retrogradely through the aorta. And what we realized is that there was always the evidence that whenever you have the maximum decrement, either retrogradely or anterogradely, maximum decrement means that you engage the slow pathway. Always this maximum decrement, either retrogradely or anterogradely, was smaller on the left side than on the right. Here, for example, you have induction of AV and RT with a jump. Whenever you have jump, by definition, means that you abandon the conduction through the fast pathway, traditionally speaking, and you go to the conduction through the slow pathway. And always this slow pathway seems to be shorter in the left than in the right side of the septum. Retrograde engagement of the slow pathway again, you see, on the left side, it is shorter than the right. And this is compatible with the histology findings in the human that always the left extension is shorter than the right. So if this represents conduction through the slow pathway, then you should expect it, as it is, to be shorter in the left than in the right. So if this is the slow pathway, the extension, where is the fast pathway? Nobody has proved where the fast pathway is, but we have reason to believe that there are similar small extensions, which are very, very tiny in order to be identified easily, from the AV node towards the atrium. And we hypothesized that this is the circuit of AV and RT. Using those small superior extensions, left and right, as slow pathway, as fast pathway, and the inferior AV nodal extensions to the atrium as the slow pathway. And this is the circuit of, we believe, of slow fast of typical AV and RT. Now, when you are dealing with atypical AV and RT, it's not the opposite as we initially thought. Atypical AV and RT most probably is re-entry engaging the two extensions, the left and the right. depending on which direction you go, you may have the so-called slow-fast or the fast-slow, the slow-slow or the fast-slow. And whenever you have extensions which are more or less equal in length, because everything can happen in human nature, then you may have an arrhythmia which is typical but cannot be classified either as slow-slow or fast-slow. So you have slow-fast, typical AVNRT, atypical AVNRT. And this actually theory can explain various phenomena. First of all, you may have sometimes the impression that AVNRT utilizes multiple retrograde fibers with HA intervals changing all the time. You may have, you see here, typical AVNRT, atypical AVNRT in the same patient. You have AVNRT being initiated by either anterograde or retrograde jumps. We used to believe in the past that you may not have an anterograde jump with a typical AVNRT. This is not the case, and all this can be explained by this theory. And you may have a patient, the same patient here, with typical AVNRT and atypical AVNRT. And this is, perhaps I understand, all this peculiar, this fascinating ways of looking at this arrhythmia that have led actually Sonny Jackman to describe AVNRT as having multiple circuits. I think that it's not right. And if you want to forget everything you know about AVNRT, you go into Zipes' book and see what Sonny Jackman says. It's impossible to realize what's going on there. My explanation is that the only way to explain actually this circuit is by the way I showed you with the nodal extensions. Now, practically speaking, what does that mean for the ablation? That means that whenever you want to ablate AVNRT, you just have to go, first of all, you need always a CS cath. It's impossible to do an AVNRT safely without a coronary sinus catheter and without a His cath to indicate where the His is. And you should always go below the coronary sinus catheter over there. That's where the nodal extension is. Away from the His, nothing to do with the fast pathway, which goes by withdrawing the catheter over there, and always in the RAO, in the PA and the other RAO views, always below the cath which goes into the coronary sinus. If you cannot achieve nodal rhythm from the right, you may go from the left. From the left, you can come either retrogradely or from the aorta or transeptally. With transeptal approach, actually, it's easier to engage the posterior part of the left septum. And if you cannot ablate from the right, then you can easily ablate from the left. Trust me, it's easier than it shows there. And what's the critical point? The critical point is to record this kind of electrogram. This is the electrogram of success. You see, the fractionated activity always having V and always having an A, and the A is less than the V. And whether you go on the right or on the left, you should expect to see the same electrogram. Whenever you see this electrogram, then you are on the slow pathway, you ablate there safely, you are not going to have AV block, and AVNRT is going to be abolished whenever you record the nodal rhythm. Our experience is more now than 400 cases. We never have AV block with this approach.
Professor Katritsis,
and when I persuaded these nice people,
Professor Katritsis, you should finish your presentation.
I persuaded these nice people to contribute with patients, and we realized that from all these cases, 100 of them with a typical AVNRT, no case of AV block by using this technique. And in order to indulge your imagination, this is a patient with dextrocardia. In dextrocardia, you have everything the opposite, as through the mirror. If you don't actually employ both the right and the left approach, it's impossible to ablate these patients. Okay, in order to make a long story short. So, in conclusion, Madam, Mr. Chairman, ladies and gentlemen, AVNRT is the most common regular arrhythmia in the human. The exact circuit is not known, but most probably it's confined in the AV node, and most probably it engages the atrial extensions to the node. The typical and the atypical forms are expressions of the same tachycardia, again. it's AV and RT regardless of whether it's typical or atypical. You can have both forms in the same patient. And catheter ablation should always target the area where the slow pathway anatomically is. In this way, you can achieve cure of this arrhythmia without any risk of AV block. Thank you very much for your attention.
Thank you, Dr. Katritsis. We'll have the questions at the end of the presentations. So now it is my pleasure to introduce Dr. Elad Anter. Thank you, Elad, for coming over to our meeting. And his topic today is circuits of reentrant VT in ischemic heart disease. Elad, please.
Thank you very much for the invitation. It's an amazingly organized meeting, and I'm very honored to be here. I'll try to do it shorter so we can keep in time. So my task was to speak about circuits of reentrant VT in patients with ischemic cardiomyopathy. So the mechanism of post-infarction reentrant VT is known. Reentrant circuits usually, I'm not sure why the slides are. Okay. So the mechanism of reentrant VTs involve few different things. One of them is dispersion of activation as a mechanism to have slow conduction due to either minimal amount of surviving myocardial bundles within scar, or due to the zigzag conduction that Dr. De Backer has taught us about, which includes multiple activation at the same time, recording from multiple layers in the myocardium, and also due to increased axial resistivity, and I'll talk about it later on, about how curvature can cause slow conduction. But slow conduction, as in the AV node, is also important in reentrant VT in patients with coronary disease to generate a reentrant circuit. But slow conduction by itself is not enough to generate reentry. You also have to have dispersion of refractoriness, meaning different cells that have refractoriness of different intervals, and the combination of different conduction properties and different recovery properties give the milieu to develop reentry. And when that happens, we see block, either fixed but most time functional, that allows a corridor for protected conduction through what we call the isthmus and around it again and again and again. Now, the mechanism of post-infarction VT is reentry. That has been proven by some people that sits in the panel here. And what we see is concealed diastolic activity that was recorded in the operating room in the first times where reentrant VTs in patients with infarction were mapped, and you can clearly see diastolic activity, but the diastolic activity is not enough. The true proof of reentry was the ability to reset this tachycardia with fusion, and this was developed by Dr. Almendral when he was with Philadelphia working with the Penn Group and Dr. Josephson. And there is even these days, the data that I'm going to show you, there's no alternative that is more modern than actually like sitting and spending a lot of hours looking on electrograms. And this is what I'm going to show you. Now, Bill Stevenson was extremely smart to take the scheme or the schema that was developed by the Josephson group and translate it into something that is much easier to understand. And this model that you're all familiar with, which represents two areas of inexcitable scar, surviving bundles in between these areas of inexcitable tissue, and generation of a circuit, and he described bystanders and adjacent bystander, remote bystanders, and inner loop, outer loops, everything that you're familiar with. But all of this, which is a very simplified way and in many ways incorrect, but it's easier to explain the circuit, was derived from this picture. Now, it's much easier to understand this picture. I'll give Bill that. Now, what have happened with VT? So from 1977 to 1984, the mechanism of post-infarction VT was defined as reentry. In the 1980s, surgical VT has started. It evolved to become a procedure that is called subendocardial resection, with an overall 80% success rate with reasonable morbidity and very low mortality. And actually, if you're able to induce and map the VTs in the operating room, you have 90% success rate, not acute, but mid and long-term success rate with very low mortality. And in 1994, the invention of the 3D electroanatomical mapping happened. Catheter ablation of VT gained popularity. I think, you know, the idea was that I'm going to stop the talk here and like we cured another disease. But that's not what have happened. From 1994 to 2016, we haven't made so much progress. VT ablation is not as successful as we want it to be. The recurrence rate is around 50%, and the recurrence rate is even higher in patients that have non-ischemic substrate despite epicardial ablation, as you've seen in the previous sessions. Now, this is a VTEC study. This is a study that was done in patients with stable monomorphic VT in the presence of coronary disease. These are like the easiest patients theoretically to ablate, done in great centers. Outcomes are not that amazing. 50% recurrence in 2 years, yes, it's better than antiarrhythmic drugs, but not by much. The VTEC study, the VANISH study that was presented also like half an hour ago, again, doesn't really show much improvement with ablation as compared to amiodarone. And the question is why? And this is the main part of my talk, and I'm going to show you what we achieved since then. So I think we use a lot of assumptions and misconceptions when we think about this construct of the reentrant VT. And let's review them. One of them is the voltage-guided ablation. It is known that if you take a catheter and you put it on a scar in the operating room, you're going to record low voltage. And this low voltage, if there is going to be conduction, it's going to be slow conduction. But what we do, we infer the opposite. We infer that if we take a catheter and record a low voltage, it means that you have scar, and it means that you have slow conduction. But that's not true. Scar does not equal slow conduction. Slow conduction does not equal scar, but many times it does in coronary disease. But the opposite is not true. We also make the assumption that circuits live in this 0.5 to 1.5 millivolt zone, and ablation there should work, and if we ablate more, it will work even better. The other issue is electron-guided ablation. Ablation of lavas, late potentials, abnormal electrograms. We see all this recent publication. Nothing is so new. It was actually described in 1984 by Dan Cassidy. Abnormal electrograms are present, but they're also present in areas that has nothing to do with the arrhythmia. And they're influenced by the wavefront of propagation, such that in this case, when the catheter is in the same location, but you pace from one side, the electrogram looks normal. If you pace from the other side, you have an isolated late potentials. What about pacemap to guide ablation? If you use pacemap to guide ablation, you assume that the barriers that form the isthmus are fixed, meaning that I can go throughout this channel and I'm going to get steam to cure that is going to get prolonged up to a point when I get it so prolonged that I will say this is an isthmus. But here you assume that the barriers are fixed, which actually in 75% of the cases they are not fixed. What about entrainment? And I'll show you examples, and Bill agrees on this. Entrainment can tell you roughly if you're in the area or not in the area, but by no means it tells you if you're in the circuit and where are you in the circuit. And we learned from high resolution mapping that entrainment tend to overestimate the size of the circuit by much. Now, I'll give you an example to back up what I'm telling you. So this is a voltage map in patient with anterior myocardial infarction, LAD infarction. This is the activation during sinus rhythm. As you can see, the activation during sinus rhythm sweeps throughout the LV without any slowing, suggesting that despite the area of low voltage and scar, there's no slow conduction at this point. This patient does not have any VTs, not spontaneous and not induced. However, this is a mapping of the right ventricle and left ventricle in a patient with sarcoid. Completely normal bipolar voltage map, but see what happens. During RV pacing, conduction does not cross through the septum. It goes all the way to the RVUT to activate the other part of the septum late. So here you have an anisotropic conduction, or maybe scar that cannot be recorded from the endocardium, that leads to a lot of VT, despite normal voltage. So what is the problem? The problem that we learn to map the anatomical substrate, voltage, abnormal electrograms, all of these are passive parameters, but not the functional entity or the functional parameters that can give rise to reentry. wherever it's going to be, atria, ventricle. We're talking about VT, so it's relevant to the ventricle. And I'll explain. Structural substrate, we think that low voltage and LG on CMR represent scar, and we assume in our heads that if you have scar, that equals slow conduction. Slow conduction is one of the parameters to induce reentry. But slow conduction can happen also in the presence of normal voltage by anisotropic conduction. What about recovery abnormalities? Areas of slow recovery, fast recovery, like slow and fast pathway. Do we even assess for this? We don't. So we don't take the second part that is important to reentry into the equilibrium where we think about identifying the arrhythmogenic substrate, not just the substrate, the arrhythmogenic substrate. The point is that we need to do more. We need to combine assessment of the structure with assessment of the function, and this is what we did over the last 5 years. In order to do that, we said, let's take a technology that was just for animals back then, that allow us to map the circuits of post-infarction VT in extreme detail, and then go back to the substrate and see what's the voltage looking like, what conduction velocity is looking like, what refractoriness in different areas are looking like, how the histology is looking like, and see if we find something that is more meaningful. And that has resulted in these publications. And I'll give you the example. That was the first case we did in a swine model of LAD infarction. I was blown away when I saw this example. It's a beautiful case of a figure of 8 reentrant VT in a pig with anterior wall infarction. We then moved to humans. I'm going to present data from 50 patients with coronary-induced VT. This is one of them. That's anterior infarction patient. Again, you have this reentrant circuit, very small circuit of VT. This is another patient that from a week ago, patient with anterior septal infarction, a VT that comes from the anterior septum, going on the septum to here. You can see here there is kind of like a lag here because it's going through the RV septum and until it comes back from the to the LV septum to go back to the entrance point. So we mapped a lot of this to be able to go back and forth and identify what is the substrate we are really looking at normal rhythm, because we can't really map most of these patients. Most of these patients that don't have tolerated VT. What can we learn from these cases that will help us with the patient we cannot map? So a few things we learned. We learned that the slowest conduction is actually not in the isthmus itself. It's not in this channel. The slowest conduction is in areas of curvature. As Andre Kleber showed many years ago in his science paper, why impedance mismatch and why areas of thick tissue that meet thin tissue and scar tissue create this area of slow conduction. So the slowest area of conduction is actually in the curvature, entrance and exit, not necessarily in the isthmus itself. We also learned, so I'll go by things that we learned by. 1, the isthmus has normal conduction velocity. 2, conduction velocities are actually dynamic. In this case, this is the same area, but the patient had 2 VTs, have exactly the opposite axis, sharing the same isthmus. The interesting part is I'm showing you like in isochronal maps, and you can see that the entrance of this VT that is, of this VT that exits at the base of the heart, the area of slowest conduction is in the entrance. And when the axis of the tachycardia changes, the slowest area of conduction is still in the entrance, but in the entrance that now is, what used to be the exit of the other VT, such that conduction velocities within the reentrant circuits are dynamic and influenced by the vector of wavefront propagation, such that the zone of slow conduction is not geometrically fixed, but rather influenced by properties of anisotropic conduction. Number 3, and that's a very important point. Multiple VTs, 5, 6, 11 VTs in a patient usually share, it's not really one isthmus, but it's one area that I call reentry vulnerable zone. One zone. And this is a striking example. This is a patient that had inferior infarction. The first VT presented with was this one, which goes around the mitral annulus, okay? Like this. And you can see there's a coronal maps and basically go like this around the mitral annulus and back. Now then he had the second VT, VT2. Map the second VT, the map looks exactly the same, identical. It's like a pivot that goes around here. Now, what's the difference? The difference is that now it's a competition. Instead of going to the septum like it's going here, follow the colors, this time it's just propagate a little bit, few milliseconds faster through the inferior wall. So you get this axis. but the area is the same area. What about this case? The catheter is positioned in the same place. VT1 changes to VT2. Look on the diastolic activity where this patch is, or this basket is on the isthmus. In VT1, this is the diastolic propagation. In VT2, once it's changed, the catheter is in the same location, propagation is reversed. The circuit can be also very small. Sometimes, circuit that looks like a mitral annular flutter, like in this case, can be actually something that goes around the size of like just a dime. And you can see here the entire diastolic activity in this area. Now, how do we know that they're small? We're not only relying on technology. Technologies help us to understand, but we have to go back to what Jesús has taught us. Resetting is important. And in these cases, when you have small circuits, you can't reset them even with double extra stimuli from from remote sites, like from the right ventricle in this case, but only when you pace from the very close area to the circuit, like in this case. It applies also to other patients with different scars, not necessarily coronary disease. In this case, this is a patient with ARVC and tachycardia that just goes around here, the RV free wall. This is all passive. It's all this like little pivot here. And from this, we also learned that entrainment, number 5, entrainment overestimates the size of the isthmus. I'll show you an example. This is the circuit here, multiple activations at the same time around this pivot point. We entrain from here, we are outside the circuit. We actually terminated this with catheter contact. Okay, that was sustained for many, many minutes, for 17 minutes. We entrain from here, concealed fusion, PPI, just 4 milliseconds longer than the tachycardia cycle length. We move even farther out. We are like 5 centimeters away. PPI, 10 milliseconds, conceal entrainment. We move farther, 20 milliseconds, still conceal fusion. This is one of these examples, being remote from the site, completely looking identical, the 12th lead of the pacing to the VT. The PPI is not that bad. It's within the normal criteria for entrainment, but we're out of the circuit. Even here, we're almost like in a different chamber. But since you have such a rapid conduction from the exit, you still can be, by entrainment criteria, considered as part of the circuit. So the circuit is here, but all of this area would be considered part of the circuit if you just use entrainment. So the last thing is that the isthmus can be identified during sinus and pacing. Now we go back. What did we learn from this to utilize in patients that we cannot map their arrhythmias? So this is the VT I showed you in the swine. Years later, once we started to get understanding that maybe we can use this information from the sinus map or the pace map to identify where the circuit is, we started looking on this. Let's just look on the activation during sinus rhythm. You're going to see propagation. Hopefully going to see, propagation coming from the base of the heart, but see what happens. You can identify at least one line of block and then perpendicular conduction here. If I just freeze it for a second, this is what you see. That doesn't look so much different from this. Now, if you actually measure also recovery, properties of recovery, you can see that this area of this entrance have very different verbs compared to the other areas. But it's not the absolute value, it's the gradients in verb. This is another case from last week. This is that I showed the VT a second ago. This is the voltage map of this patient with anteroseptal huge infarction. This is the circuit. He had several VTs, all of them were contained within this area. Where will you ablate here? You'll have to ablate the entire, it's going to take you days to ablate the entire thing. But if you look on the activation during RV pacing, we did the activation. This voltage map was generated during RV pacing. Now you can see that you identified one line of block, probably one here, and you make the whole story much smaller to identify areas vulnerable for reentry. So why is it important? It's important because potentially you can just do this ablation. You can identify this core that is vulnerable for reentry and ablate this rather than do this, like a lot of groups now do homogenization of everything. Now, you can say, you know what, so what? We use, maybe we have 100 lesions compared to 30, we use an hour more of procedure time, more fluids, but it's not that bad. But I'll tell you what's the problem. The problem is that if you do this, you really think that you're ablating so much, you're not. This is another study we haven't published yet. This is like, ablation in a ventricle, in a normal ventricle. See how beautiful and well demarcated scar you create when you put, in this case, 40 watts, 60 seconds of an RF thermocool catheter. Very nice. Try to do this with scar. This is scar. Where is the lesion? You can hardly see the lesion. The amount of cells that we ablate in scar with RF is so limited that it's unbelievable. Now, you can say, okay, you do this, but how do you know that not going to be other VTs coming? We don't. We don't set up our goals or our conclusions. We may be wrong, but we made this assumption and we went forward this and we did comparison of standard ablation of hemodynamic tolerated VTs by entrainment, and substrate ablation like we typically do in patients with VT, versus this approach that I've showed you. And we compared 32 patients for 2 years follow-up. And you clearly see that there is with this approach, you have significantly better outcome. In 2 years, 15% recurrence rate compared to 34% recurrence rate, and we reduced the RF time by 56%. The p-value is not significant. It requires much more prospective evaluation and so forth, but at least it's promising. The summary. Current substrate mapping techniques of VT are non-specific and non-sensitive. Assessment of the functional, quote-unquote, arrhythmogenic substrate is probably superior to standard mapping of the anatomical substrate. The size of the arrhythmogenic substrate is significantly smaller from the entire size of the low voltage area. Multiple VT morphologies usually originate from 1 or 2 areas that are vulnerable for reentry. Mapping and ablation of reentry vulnerable zones may be more effective and potentially safer if it's shorter than standard ablation techniques, but the implications for mapping and ablation for other substrates, including non-ischemic cardiomyopathy, where you may not be able to detect any of these substrates from endocardial mapping, may not be applicable and require further investigation. Thank you very much.
Thank you very much, Elad Anter, for this outstanding presentation. Very nice pictures, very nice information. And now we are going to move to the next presentation, which is early repolarization, and Dr. Heikki Huikuri is going to present.
Okay, Chairman, dear colleagues, I also want to thank the organizer for inviting me here to Madrid, a very beautiful city. I didn't come from northern Finland. Actually, I came from South Tenerife, and it was much warmer there than here. But I must go back to Finland next week. So, okay, my presentation is now moving from the intracardial electrocardiograms and invasive EP to standard ECG. What standard ECG actually can tell us about, and my topic is early repolarization. These are my disclosures. As you many know, it was very common sense that early repolarization in the leads V2 to V4 is a very benign finding, and actually it's kind of ECG marker of healthy young people, until in 2008 Michel Heisager and his colleagues found out that it's quite prevalent to find this type of pattern, particularly in the inferior or lateral leads of the standard ECG in those patients who had so-called idiopathic ventricular fibrillation, so without any structural heart disease. And he found out that this type of pattern in the ECG was predictive of recurrent VF events of ICD patients. And since that, this concept has been actually confirmed in very many different other places, mainly in Israel and in Asia and some other centers in the world. And actually, this is the case that in people who have had a ventricular fibrillation and they have been resuscitated successfully from such an event, it has been found that around 30 to 50% of these people have actually this type of ECG pattern. And compared to control patients, control people, where the prevalence of this pattern is between 2 and maybe 10%. So we did in Finland then a study of the general population, that we know that we had ECGs collected in the general population in late 60s, and with a very long follow-up. And we wanted to see what is the prevalence of this type of ECG pattern in normal population, and what is its prognostic significance. And we had more than 10,000 participants, and we found that this type of ECG pattern can be observed in 5.8% of the people. And when we did the repeat ECG in these patients later on, we found that this is more or less a constant phenomenon. And 92% of the people had the same pattern 5 years later. These are the patterns that we are looking for. There are two patterns, so-called slurring of the T-point elevation and so-called not T-point elevation. Actually, nowadays this pattern is called J-wave syndrome, and it's in relation with Brugada syndrome, which is also one part of the J-wave syndromes. And you must know that this is only in the inferior or in the lateral leads, not in anterior precordial leads. And what we found in this study was that this pattern, particularly in the inferior leads, was associated with increased risk of sudden cardiac death, and this was published in England Journal of Medicine in 2009. And we found that very high amplitude J-wave elevation in the inferior leads was stronger predictor of sudden cardiac death than many other very previously known electrocardiac risk markers of sudden cardiac death. And this was then replicated in another Monica Cora population from Germany. Actually, quite the same results, that this pattern was associated with increase of sudden cardiac death. And then this is the result of the meta-analysis showing that early repolarization pattern is particularly predictive of sudden cardiac death here, death from arrhythmia, but not the other modes of cardiovascular mortality. Then we combined the findings with the Framingham heart study and with another Finnish population, and found that this is an age-related and gender-related phenomenon. Early repolarization is very common in young people, and its prevalent declines with aging. And this seems to be a testosterone-related phenomenon, because we know that the higher testosterone levels, the people who have high testosterone levels have a higher prevalence of early repolarization. But what was surprising, that we know that in young athletes this type of pattern is very common. But this type of pattern has some specific features. As you can see here, there's very rapidly ascending ST segment after T-wave elevation. I think it's quite similar with the J-pod elevation in the anterior leads. Then we went forward and from our population and found that this type of rapidly ascending ST segment after J-wave elevation is actually a benign phenomenon, but if the ST segment is horizontal or downsloping the J-wave elevation, it carries a higher risk. So this type of rapidly ascending J-wave elevation actually seems to be very benign phenomenon, and it's commonly observed in young people and young athletes, in male athletes. And then the Israel group also was looking in their database of survivors of ventricular fibrillation, and they found that this type of ascending ST segment after J-bend elevation is common, but it's benign. But in those who have resuscitated from ventricular fibrillation, the most common pattern is horizontal or descending ST segment following J-point elevation. And this was quite interesting after this observation that Naruse and the collaborators saw that if the people have had ECG before they experienced an acute ischemic event, and they had this type of early repolarization pattern, they had a very high risk of having ventricular fibrillation at the time of ischemic event. So despite this early repolarization syndrome, this type of pattern seems to increase the risk of ventricular fibrillation in case a patient get an acute coronary event. Actually, we confirmed the same thing in our case control study, showing that in sudden cardiac death survivors who had an ECG before the death, this type of early repolarization pattern was more common, and it was this type of horizontal or descending ST segment pattern. So what is the overall risk of if you find in a normal people who has an ECG recorded for any reason? We can say that the risk is very low. It's much lower than those with the Brugada syndrome type 1. But still the risk is higher than in those who do not have this type of pattern. And there are many other features that actually separate the benign patterns from more malignant patterns. The higher the amplitude of the J-wave elevation, the higher the risk. And then there is in these patients people who have resuscitated from ventricular fibrillation and who have this type of pattern. It has been shown that it's very common that it's a dynamic feature. Sometimes the J-wave disappears, and in another ECG you can easily find it. And it's bradycardia dependent. At slower heart rate, you can find more easily the J-wave elevation. This is the pyramid that we created to highlight some issues. So if there's rapidly ascending ST segment in the lower part, it's very prevalent, but it's more or less benign. And in inferior leads, this J-wave elevation pattern seems to be more malignant. And if it's high amplitude, higher the risk. And when there are dynamic changes and very high amplitude, the risk is much higher. There are other features, of course. If you see the ECG with the early repolarization patterns, that should be considered. If the people have a family history of unexpected sudden cardiac death, and if this person has syncopal episodes suggesting to arrhythmia, and if the ECG shows high amplitude and wide distribution, J-wave elevation with horizontal descending ST segment. In these people, you should perhaps perform Holter recordings to see if they are very early ventricular premature beats, which are very suggestive of the higher risk of getting ventricular fibrillation. This pyramid now summarizes the ECG and clinical features. So it's a very high risk if you have a family history of sudden cardiac death, high amplitude of J-wave elevation, and if you have a short-coupled VPBs, and if it's some dynamicity in the J-point elevation. And more widespread, if you have, in a combination, if you have Brugada type 1 ECG pattern with early repolarization, those people are really at a high risk of ventricular fibrillation. This is from the consensus report recommendation. What should we do? ECD implantation should be considered only in those who have a very high risk ECG pattern, and a strong family history of sudden cardiac death. And but ICD implantation is by no means recommended in asymptomatic patients with isolated ECG pattern of early repolarization. What about if you have patients who have syncope and early repolarization pattern? You know that vasovagal syncope is very common. And then you have to consider many other options, perhaps put an implantable loop recorder for patients with repeated syncope to show that if it is really caused by polymorphic ventricular tachycardia, and if the patients have a strong family history of sudden cardiac death, you must perhaps referral to a specific arrhythmic center may be useful to do some genetic testing, because there are some gene mutations found causing this type of early repolarization syndrome. This is one case from the real life. This is a 52-year-old asymptomatic man who was referred to exercise test because of the strong family history of sudden cardiac death. And his ECG saw a typical early repolarization pattern in the inferior leads, which was a quite high amplitude, and it disappeared during the exercise as it usually does. He has a little bit elevated LDL cholesterol, no smoking, normal blood pressure. Well, in this type of people, we don't have any guidelines, but we know that if this patient actually gets an acute coronary event, he is at higher risk of having ventricular fibrillation, so you may consider a more aggressive antithrombotic therapy with statins and aspirin in this type of case. These are my conclusions. If you have an early repolarization pattern in a young subject, do nothing. Do not even tell him or her that you have this pattern. But if you have a high-risk pattern with a high amplitude and with a descending ST segment, I think you had to address all modifiable risk factors for acute coronary events. And if you have patients with a malignant pattern of early repolarization, consider a loop recorder or quinidine. Samivyskin is using quinidine in these patients because it prevents the events, and perhaps consider referral to a specific arrhythmic center. Thank you very much.